So, good morning, everyone. Today we will talk about the neck masses in children. This talk will be presented by our colleague Dr. Kania Hussein. She can start. Thank you.
Good morning. My subject is about neck masses in children. As we know, neck masses in children is very common and faces pediatrician every day. So, after examination and history, they will refer the case for a radiologist, and we as a radiologist, we should know how to deal with such a cases. We will decide the modality for imaging, and we will choose first ultrasound, because ultrasound is non-invasive and simple modality for examination, no radiation, and it will give the definite diagnosis, especially if the lesion is cystic. MRI is used for larger lesions that infiltrate to deep spaces. CT will be used for acutely ill patient with infection, abscess. PET scan is used for staging if the case was suspected to be a malignancy. So, ultrasound will help us to decide whether this mass is cystic or solid. If it was cystic, we should look to the content. If it was clear cystic, it will be straightforward for the diagnosis. But the problem if the cyst was not clear, if it contained echoes or debris. Now I will explain later how to elicit swirling of the content by the probe of ultrasound. We have also solid lesions, either lymph node or non-lymph node solid lesion. Lymph node, we have reactive lymph nodes, lymphadenitis due to TB or cat scratch disease, and malignant lymphoma. Other solid lesions that not a lymph node, we should look for the site of origin, either from salivary gland, thyroid gland, or sternocleidomastoid muscle, or it will originate from subcutaneous tissue, such as pileomatrixoma, lipoma, or hemangioma. This is what I talk about when the lesion is not purely cystic, how to differentiate from a solid, either by compressing with the probe or by asking the child if he can to move or sit. The content of the cyst, we will see, it will move. This will call swirling. If it's clear to you, this improves that this lesion is cystic, not a solid.
So you see, when you see the lesion, you just try to move it to make the fluid inside it move to confirm that it looks like a lymph node, but if you move it and the things inside moves,
or ask the child to sit.
Yeah.
This
indicates that this is a thick fluid rather than solid.
And this thick fluid may came from inflammation or from hemorrhage. So, I will start by cystic lesion. In cystic lesion, we should concentrate on location, location, location. Why? Because we have midline lesion and off-midline lesion. In midline lesion, we have three common lesions, such as thyroglossal duct cyst, ranula, and dermoid cyst. Off-midline lesion, most commonly like branchial cleft cyst and lymphangioma. Branchial cleft cyst often contain debris, while lymphangioma either will be anterior or posterior. The anterior one will be multicystic, and the posterior one is often single. First, I will talk about this what I said, cystic lesion either midline or lateral. Midline, if it was in the upper midline, it's most commonly ranula. This according to location. If it was in the mid near the hyoid bone, it will be thyroglossal duct cyst. If it was in the suprasternal notch, it is mostly dermoid cyst. This regarding midline lesions. While off midline lesions or lateral lesions, it is either branchial cleft cyst or lymphangioma. As I say, to differentiate, lymphangioma have anterior and posterior one. The anterior will be small cyst and will be echogenic, while the posterior one will be unilocular cyst and will be anechoic. This as a general. I'll start by thyroglossal duct cyst. It's very common and compromises 70% of congenital neck masses in children. As we know in the embryology, the thyroid gland will originate from foramen cecum in the base of the tongue here, and it will transmit through a duct to reach its final position in the neck. This duct, if didn't involute, thyroglossal duct cyst will develop. And it will, this duct will pass in the midline to the hyoid bone. After hyoid bone, it's split. So if this is developed above the hyoid bone, it will be midline. If it was below the hyoid bone, it will be off midline. Because of it will split. Our imaging modality that we use is ultrasound. It's the gold standard. We don't use CT unless the cyst was very large and to see the capsular enhancement when it's infected. When I said from beginning, CT is for infection and abscess. While thyroid scanning may be done to rule out the cyst containing only functioning thyroid tissue. We may not see the thyroid in its place, and this cyst contains the only functioning thyroid tissue.
Thyroid scanning, we are not talking about ultrasound, we're talking about thyroid scintigraphy.
Yes, yes.
Nuclear scan.
Yes, other modality. So in ultrasound, we will see a well-defined anechoic or hypoechoic with internal echoes if hemorrhage or inflammation occur, or it contains proteinaceous material. If it was suprahyoid, it will be midline. If it was infrahyoid, it will be a little bit off midline. But always look for the presence of normal thyroid gland and make image for it during ultrasound.
Why?
Because maybe the only thyroid tissue you have inside the cyst.
First, you might have, if the thyroid, the original thyroid is not seen,
yes,
the cyst might contain the only functioning thyroid.
Yes.
So you don't remove it.
Yes.
Or you don't recommend that the surgeon remove it. This is first.
Yes.
Second, ectopic thyroid tissue within the cyst is also liable for thyroid carcinoma.
Yes, in adult,
okay.
Mostly.
So it might be removed as part of treatment of thyroid carcinoma if there is any suspicion.
Yes.
How it contains thyroid tissue?
By scintigraphy we will decide. No, maybe contain, it will, it's the tract that the thyroid passed through it from the foramen cecum to sometime it stop the thyroid in the midline near and develop with the cyst. The thyroid will be inside the cyst or with it. So by thyroid scintigraphy we will decide cyst contain thyroid tissue or not. Sometimes it's isoechoic, not hypoechoic. A differentiation point for this thyroglossal duct cyst that's connected to the hyoid bone, so it will move during swallowing. Or if the child is big enough, we can ask her to or him to protrude the tongue. As we see in this video, movement of the thyroglossal duct cyst during protruding the tongue or swallowing. This is what I talk about, this off midline thyroglossal duct cyst that is developed infrahyoid. This is CT. The wall may be enhanced due to infection. And it will be, if it's infrahyoid, this is infrahyoid, it will be off midline and it will be trapped or behind the strap muscles, its location, because in the upper superior to hyoid we have no strap muscle. So inferior to hyoid, if present, it will be beneath the strap muscles. Yes. Second, congenital neck mass is ranula. Ranula, it will be upper than the thyroglossal duct cyst, as I explained it from beginning. It will be a fluid-filled cyst due to mucus extravasation from traumatized sublingual gland. Extend into soft tissue or floor of the mouth. It may be seen by examination, as we see here. This is called simple intraoral ranula. Sometimes it is deep, not seen on inspection. This is called plunging. Okay. Here we have by ultrasound anechoic mass continuous with the sublingual salivary gland. Most goes with ranula, especially if we see the mass. So if it extends over the mylohyoid muscle and then called plunging ranula. Here we see this is the mylohyoid muscle. If the ranula was deep to it, it will call plunging ranula. Here we need CT or MRI, better for evaluation. And also called submental or submandibular mass. Third subject is dermoid cyst. Dermoid cysts are inclusion cysts that contain epithelium, skin adnexia like hair follicle, sebaceous gland, and sweat gland. They compromise 7% of head, neck, mostly occur in the head and neck around the eye in the outer border here. And if occur in the neck, it will be in the midline in the suprasternal notch. This in children. But their echogenicity will differ on ultrasound. On ultrasound, if it was in the neck, it will be hyperechoic, midline. How to differentiate it from thyroglossal duct cyst? Thyroglossal duct cyst is usually hypoechoic and may contain internal echo, but it moves with swallowing, while dermoid not move with swallowing and always hyperechoic. And so homogeneously hyperechoic, not just turbid fluid like thyroglossal duct cyst. If it was near the outer corner of the eye, it will be hypoechoic. But here we should make sure for the integrity of the bony lining, because it may extend into the intracranial.
At the orbit, it's hypo.
Yeah.
At the neck, it's hyper.
Hyperechoic and homogeneously hyperechoic. Not moving, yes. Thyroglossal duct cyst will move on swallowing. This not move.
Good.
Here we have. If you are suspicion on ultrasound to look if there is extension intracranially.
Usually the surgeons will send for CT or MRI.
Yes,
usually,
before operation.
Even if you reported not connected intracranially.
Yes.
They want to be sure that there is no intracranial extension. The surgery will be different.
Here we have a CT. This midline dermoid contain hypodense granules of fat, and this is called sac of marbles. It's typical for dermoid. Here in ultrasound, and this is CT of the same patient. I finished midline lesion. I will shift to the off midline lesions. We have on the top branchial cleft cyst. What are the branchial cleft cysts? On embryology, we have branchial cleft or pharyngeal cleft. We have about 6, and if these clefts do not persist, it will form either fistula, sinus, or cyst. And we have 4 types or 4 division. The second one is the most common. Cyst at the level of the thyroid gland can be remnants of the 3rd or 4th branchial cleft cyst. So, if there is incomplete obliteration, it results in either cyst occupying 75%, a sinus, it has 1 opening, or a fistula with 2 openings. The first one, it will be near the external auditory canal. It will also have 2 types. Either it's located in the near external auditory canal or in the submandibular region. The second one, its typical location is anterior to sternocleidomastoid, lateral to the carotid vessel. The third one and the fourth one will be near the thyroid gland. And the second one also have subtypes. That's the most common one. They present as a painless mass or suddenly after internal hemorrhage the baby come. Maybe not symptomatic until it bleed or infected. This is the first one, as I mentioned, it's located near the auricle.
The first branchial
Yes, the first branchial cleft cyst. It has also 2 types. Type 1 is close to external auditory canal, type 2 at the submandibular region. Also may open to external auditory canal. So there is close relation to the external auditory canal. Yes, here we see.
You can see this cyst
and this.
And opening into the external auditory canal with some surrounding inflammatory changes.
Yes. This is the first one. The second one, which is the most common, compromising 95%, it's located along the anterior border of the sternocleidomastoid, lateral to the common carotid artery, and if more cranially between the internal and external carotid artery. Sometimes this is called a beak sign between the internal and external carotid artery. On ultrasound, we will see often a cyst with internal debris caused by either cholesterol crystals or due to hemorrhage. Trauma to the neck may cause hemorrhage or infection. It will be compressible except if the fresh internal hemorrhage. If there is inside it fresh internal hemorrhage, it will not be compressible by the probe. This is another branchial cleft cyst, typical location, superficial to the carotid bifurcation. Its location is typical here. Yes, transverse. If the if that cleft have opening, one opening, it will call sinus. If two opening, it will call fistula. Fistula will have an opening to the skin. Here we see branchial fistula, and can be demonstrated on fistulogram or MRI. Here we need MRI, because even if we see the distal opening, we cannot see the proximal opening to where it go. Here we have ultrasound, the tract is seen, but it's usually not possible to see the proximal ending. So MRI or fistulogram here.
What you do, you just bring a cannula, normal cannula, and you try to cannulate the orifice of the cyst. You inject some contrast into it, and you either do X-ray or CT scan to see where is the tract going, how deep, how many branches, where does it open, the whole details, so that the surgeon, when he goes in, he knows where to cut.
Yes.
Which one is better, MRI or fistulogram?
It depends. The MRI will help you to see the gross pattern. Fistulogram will help you to see the side branches of the fistula to all distant. The best thing is to do both and correlate.
The third and the fourth one are not common, and they occur in the left side mostly, near the thyroid gland. Second, of midline lesion, we have lymphangioma, or what called cystic hygroma. They are common cystic lesion due to lymphatoid malformation. Majority occur in children. A key finding feature is it's transfacial. This means it not respect any fascia. It goes from superficial to deep and not respect any fascia in the neck. This is the key imaging finding of lymphangioma. 90% of lymphangiomas occur in the head and neck. If it was in the posterior, it will be one or more large cysts. It appears as a large cyst. If it was anteriorly, it can consist of small cysts, and it will appear hyperechoic due to the wall of the small cystis, and this is called hygroma coli. So on ultrasound, the appearance will depend on the size, as I mentioned. If it was large, it will appear anechoic. If it was small, it will appear more echogenic and located anteriorly. So it appears on the size and the number of the cysts. Here we have typical lymphangioma on ultrasound and extending through the fascias. Also we have here ultrasound image of lymphangioma, multiple cysts. On MRI, they will appear as fluid level, and also not respecting the fascia, as I mentioned, and extending from anterior to posterior.
So this is the posterior type, there are multiple cysts, right?
Yes.
The anterior should be single cyst.
No, the anterior should be small cystis and small echogenic wall. It will appear more echogenic, while the posterior will appear one or two cysts, not more. This anterior extending posteriorly, this one. Posterior or same, both anterior and posterior. Third, of midline lesions, what called jugular ectasia, child present with a swelling in the neck on straining or crying. So, due to dilatation of the internal jugular vein, can be demonstrated by ultrasound, and there is variation in the caliber of the vein during crying and straining. It will increase. So, this will differ from what called varix, which implies dilatation plus tortuosity. This only dilatation on crying and on straining, and appear not always, intermittently. Here we see non-crying, the diameter differ from that on crying, increased, and there is a difference between the right and the left side, mostly unilateral. I will go to the solid lesion. Solid lesions either lymph nodes or non-lymph nodes lesion. Lymph nodes, we have three types: reactive lymph nodes, lymphadenitis, lymphoma. Solid, we have thyroid lesions, fibromatosis coli, pleomatrixoma, ectopic thymus. This is division of the lymph node level in the neck, as you know. This is level 1, submental and submandibular. And level 2 will be along the internal jugular vein, but above the level of the hyoid bone. You see here the hyoid bone, it will be above the hyoid bone. Level 3, also along the internal jugular vein, it located between the hyoid bone and cricoid cartilage. Level 4, it will be below the cricoid cartilage. Level 5 will be posterior to sternocleidomastoid, and level 6 will be anterior to thyroid, while the suprasternal group will call level 7. We should know the normal appearance of a lymph node. It will be oval shape or what called reniform shape with echogenic hilum and internal vascularity in the hilum. All the children between 4 to 8 years will have palpable lymph node. Near 90% of children, palpable. And on ultrasound, always you will find the lymph node. We should differentiate between
Keep that in mind.
normal.
Again,
90% of children will have a palpable lymph node.
مو كل ما تشوف
And
lymph
all
node
of them-
طفل صعد عنده lymph node 90% they have palpable lymph node مو بس lymph node biopsy.
Just for numbers.
Okay?
And all of them will have lymph node on ultrasound. So we should differentiate either it's normal lymph node, reactive lymphadenitis, or lymphoma. Normal lymph node, as I said, it will be sharply delineated, oval, echogenic hilum, and short axis not be more than 10 millim, except for jugulo-digastric group here, short axis may reach 15 millim.
Normal.
Jugulo-digastric, yes, here, anterior to sternocleidomastoid. It's normal in
When
children.
you see a big lymph node just behind the mandible, don't worry, it's normal.
Yes.
What about submandibular?
The size is not important. The shape of the lymph node is important. 10 millim for submandibular. And jugulo-digastric, 15 millim. Here. Yes. Near the sternocleidomastoid. It's not submandibular, it's jugulo-digastric.
You always see it immediately behind the mandibular angle. Always.
Yes.
It's a big one.
So enlarged lymph node in children are very common. Mostly they are reactive. Reactive to what? They are reaction to a nearby infection, either pharyngitis, tonsillitis. Less commonly it is lymphadenitis. But if supraclavicular lymph node enlarged, should always be considered to be malignant until proven otherwise. Here the supraclavicular lymph node level 7, as I mentioned. I will start by first one, reactive lymph node. It's a reaction to a nearby inflammation. They are slightly enlarged, more hypoechoic than normal, with a broader echogenic hilum. This is a 6-year-old boy with weight loss, fatigue, and lymphadenopathy. On ultrasound, we have string of enlarged lymph node with preservation of the echogenic hilum. Excision biopsy revealed reactive lymph nodes. Yes, reaction to other infection, not the infection of the lymph node itself. This is called reactive lymphadenopathy.
Anyhow, it is any more hypoechoic. The cortex itself is hypoechoic.
It means it's you see the normal one, it will differ.
Very hypoechoic.
Yes, it
You
will
can
be
see
enlarged,
The cortex is,
and the
although
baby
it
is
is-
suffering.
Although it is it's still hypoechoic, but it is little bit more echogenic than normal. First. Second, the differentiation between the cortex and the center is less
Yes,
prominent, so indicating somewhat increased echogenic.
and the baby is suffering.
Third, the history she gives you is weight loss, fatigue, and lymphadenopathy is a little bit suspicious.
Yes,
Fourth, keep in mind always there is no criteria on
Yes.
all radiology to determine whether a lymph node is malignant or benign except for PET scan.
yes,
This is the final, okay, on radiology, apart from biopsy, okay? You cannot say this lymph node is benign or malignant except by PET or biopsy. The size can help to guide you, but it does not indicate it's a benign or malignant lymph node. You can see a big reactionary benign lymph node, you can see a small malignant neoplastic lymph node. All it does is just
size not
helps
important.
guide you.
Yes, size
That's
not very
it.
important.
So
If you're about the PET, it is sensitive, but it's not specific for.
Yeah, it can tell you there
Even
is
the
a high,
reactive will be positive, I think.
but there's something called SUV, okay?
Because they-
The uptake value, if it is more than certain point, it is highly in favor of malignant lesion. It's less than this part, differs according to the organ and according to the physiological state. If it is less, it will indicate there is some sort of inflammatory process or hypermetabolic process other than malignancy.
So always you need biopsy for large lymph node.
No.
If it is not responding to treatment,
Follow
yes.
up. First, we follow up the case. Wait and see. If not respond to treatment, then biopsy. Here we have also reactive lymph node. They are enlarged with preservation of the hilum and normal perfusion. On wait and see, the node slowly shrunk. Here we have patient with pharyngitis. Here we see a lymph node enlarged at the level 2 and with perinodal inflammatory change. It is enhancing also. Also look to the retropharyngeal edema. So this is a reactionary lymph node. Even it's large.
One of our colleagues here it was so sad. My son has lymphoma. Yeah, but he does not have lymphoma. He has multiple lymph nodes in his neck, and they are hypoechoic, rounded, together. Told him, okay, give him course of treatment. It might be just infectious mononucleosis or pharyngitis or whatever. And after only everything went away, alhamdulillah, shukr. You don't jump immediately to the worst diagnosis just because a child has a lymph node. Okay?
Second is lymphadenitis. This differs from reactionary lymph node. We should not say on reactionary lymph node this is lymphadenitis, because lymphadenitis, it's infection of the node itself, and it's mostly viral and bilateral. If it was bacterial, it's often due to staphylococcus or beta hemolytic streptococcus. The bacterial one will have acute onset and usually unilateral, while the viral one will be bilateral. The bacterial one frequently located in the submandibular region. They are painful and the skin is warm and red. This for lymphadenitis. Here is a 1-year-old boy with a swelling in the neck for 3 weeks. Partly we have liquefied lymph node with infiltration of the surrounding subcutaneous tissue, we see, and this swelling disappeared after antibiotic. What's the signs of liquefaction? Signs of liquefaction are areas with detectable wall. We see the wall of the lymph node, but the center is hypoechoic, or areas with mobile moving echo reflections. And abscess formation is clinically difficult to detect. Ultrasound also is not reliable. CT is better for abscess in the lymph node. Another subject is cat scratch disease. It's not common in our community, but in community that they have cats in the home, it's very common. It's caused by Bartonella due to scratch or bite from a cat. It's the most common cause of chronic axillary lymphadenopathy. On ultrasound, the affected nodes are round, heterogeneously hypoechoic, hypervascular, with some surrounding inflammation. They are tender but not painful. And it's difficult to distinguish this lymph node from malignant nodes. So, this is a child, 16-year, who treated for recurrence of acute lymphatic leukemia. 6 months after the last treatment, she developed swelling in her left shoulder, hypoechoic node, excised, and the final diagnosis was surprisingly Bartonella.
It's such a bad luck.
Yes.
يعني هم recurrent هم acute lymphatic leukemia وهم recurrence وهم cat scratch.
We have also mycobacteria that occur in patients between 1 to 5 years. Most often, we see a palpable mass in mycobacteria. The enlarged lymph node, mostly single lymph node we will see, and the skin overlying it will be red, there will be redness, and it's located in the periauricular or in the submandibular region. So it's mostly come with single lymph node and other small satellite lesion. This central necrosis seen with thickening of the overlying skin and surrounding inflammation, calcification present especially after treatment in lymph node caused by Mycobacterium bacilli. Here we see 3 months later, swelling is still present, the deeper lymph node has liquefied, and after another 4 months, lymph node had undergone liquefaction and discharged in the surrounding tissue. Here we see calcification, fine calcification in the lymph node, also caused by Mycobacterium. Malignant lymphoma. Malignant lymphoma, we have either Hodgkin or non-Hodgkin. The Hodgkin one will be in the cervical, affect the cervical node, while the non-Hodgkin one will affect the Wilder ring or parapharyngeal, often involved. So, Hodgkin will affect the cervical lymph node. On ultrasound, the lymph nodes are hypoechoic, round, homogeneously hypoechoic, with loss of the echogenic hilum. Diagnosis is by biopsy or excision. But PET scan will demonstrate the extension of the disease. Here we see 14-year-old boy with painless swelling, always painless most of the time. Painless swelling in the left neck. Ultrasound shows several hypoechoic nodes and lack the hyperechoic rim. Here we see multiple lymph nodes. Another case with painless swelling in the left neck. Also ultrasound shows several enlarged lymph nodes. This is the MRI and the PET scan. We see multiple lymph nodes extending to the mediastinum. This is Hodgkin lymphoma.
It's big lymph nodes surrounding all the mediastinal vessels at the root of the neck also.
Yes.
And the thing is, usually there is dramatic response to treatment. If this patient given treatment, you see him after like 3-4 months, it's like a whole new person,
yes.
new person. You don't even recognize who's this. Usually they respond amazingly to treatment.
It's not the type.
Yeah.
So here the size is not very important. The shape is very important. I will. How to discriminate between lymphadenitis and lymphoma. Lymphadenitis, there is surrounding inflammation. Here, no surrounding inflammation, it's sharply delineated in lymphoma. In lymphadenitis, the lymph node will be heterogeneous, while in lymphoma, it will be homogeneously hypoechoic. Central liquefaction present in lymphadenitis, while lymphoma hypoechoic. It's unilateral lymphadenitis, often one level affected. Here, several levels affected in lymphoma. The lymphadenitis lymph nodes are tender, while no tenderness over lymph node in the lymphoma. This is very difficult on ultrasound. Not always we can discriminate. I'll shift to the solid lesion, but not lymph nodes, because solid lesion was most commonly lymph node, and least common was other lesions that come from thyroid, thymus, or from muscle and subcutaneous tissue. I'll start by thyroid lesion. We have first congenital anomaly. Most common congenital anomaly is either partial or complete absence of the thyroid gland. Always search for the thyroid gland, remnant of the thyroid gland, in the tract that I mentioned in the beginning of the thyroglossal duct. Here we see complete agenesis in a newborn child with abnormal thyroid function test. If it presents ectopic thyroid, it will be near or in the tongue or in the lingual thyroid. Second one is thyroid nodules. It's very common. It's either simple or it's either single or multiple. Some are purely cystic, but most are solid. It will be isoechoic within the normal gland. Need no treatment. Just it will stay. Most of them stay unchanged over a year. On ultrasound, you will face on examination of the thyroid of a child. Thyroiditis, we have either Hashimoto thyroiditis or Graves' disease. Both will cause enlargement of the thyroid gland, and may both of them cause hyperemic thyroid. But mostly Hashimoto thyroiditis, autoimmune disease, it presents with hypothyroidism, and the gland will be enlarged, and it will have normal perfusion, mostly.
I saw several reports from many of you. This appearance is diffusely heterogeneous echo pattern. These are not small nodules. A lot of you report as multiple bilateral small nodules in the thyroid gland. No, this is just diffuse heterogeneous echo pattern. May have increased or decreased vascularity, and it is indicative of thyroiditis, not a goiter. Do not recommend FNA. Okay? There are no nodules. Every day in the FNA department, we have 2 or 3 cases with that appearance that are reported, that they were reported by some residents as multiple small nodules. Yes, every week.
But in Hashimoto's thyroiditis, there will be nodularity, not micronodularity.
Okay, you don't report nodules.
Diffuse disease,
because they will ask for FNA, which you will, first you most likely have some sort of complication. They are vascular thyroids. Second, it doesn't need.
Because sometimes subacute and chronic Hashimoto thyroiditis grossly show micronodularity.
Okay.
That is mentioned.
This appearance is just diffuse heterogeneous, rather than
this picture of acute.
Okay.
This one, the right side. These 2 small, as if
No.
they are nodules.
As if, but they are not.
Hashimoto thyroiditis, in the later stage, the gland will shrink. Graves' disease, also enlarged thyroid gland with increased perfusion. On color Doppler, it has been described as inferno in red and blue, as we see here.
Do you know if we can differentiate between Hashimoto and Graves just by color Doppler?
Even by color Doppler, sometimes Hashimoto will come with increased perfusion.
Just we should write thyroiditis.
Yeah.
Yes,
I just right.
they will depend
Thyroiditis.
clinical
Clinical Graves.
Hyperthyroidism.
hyper,
Hyperthyroidism.
hypo.
Hashimoto can present as anything.
Yes.
Anything can be like Hashimoto.
Because Graves is most likely hyper.
Yeah. But again, Hashimoto also can be like
Thymus is located in the upper mediastinum. With increasing age, its echogenicity will increase and become more granular. Ultrasound is ideal to demonstrate the thymus as a cause of widened upper mediastinum in infants, especially in chest X-ray. Sometimes it causes swelling in the suprasternal notch on straining. The mother will complain. Ectopic thymus may occur anywhere along the path of descent through the thymopharyngeal duct. When it presents a neck mass, it can be mistaken for a tumor. The ectopic part of the thymus has the same echo characteristic as the normal thymus. Here, a 6-month-old boy with vocal cord paralysis, ultrasound confirmed ectopic thymus. Here we see, with identical sonographic characteristic as orthotopic thymus. Here also on MRI, we see the thymus located between the submandibular and the parotid gland. It's ectopic thymus. Another subject is fibromatosis coli, swelling of the sternocleidomastoid muscle in newborn due to pressure necrosis of the muscle during delivery. Previously was thought it's due to hemorrhage, but now it's proved that's due to necrosis from delivery, and especially in babies that born in breech. It occurs 1 to 3 weeks after birth, and sometimes baby will have torticollis. Usually it regresses spontaneously within a few months. Here we see enlargement of the sternocleidomastoid muscle. The sternal head is always affected. Yes, it will be either hypoids or hyper. The important is enlargement. Vascular anomalies, we have hemangioma, it's benign, most common tumor of the infancy, 60% in the head and neck. It usually appears in the first weeks after birth, will show rapid growth and followed by spontaneous involution. We see here, and a hemangioma with increased vascularity. Venous malformation also appear as a lesion in the neck, but the important is to differentiate between hemangioma and venous malformation. The differentiation is mostly that the venous malformation is composed of vessels that increase in size during straining, and on color Doppler, the lesion will show increased flow while crying. Increase in size and flow of the blood during crying and straining. This is the only differentiation point between hemangioma and venous malformation. Pleomatrixoma, it is epithelial inclusion cyst. It's a benign skin lesion associated with hair follicles. It presents as a firm, mobile, painless swelling in the face mostly, or in the periauricular region. It have a blue discoloration. Here we see, and here. Its size is either few millim to 3 cm. On ultrasound, it will appear as a hyperechoic oval shape between the cutis and the subcutis. Here we see between the cutis and the subcutis. Sometimes calcification may be seen and aquastic shadowing. The wall is often hypoechoic. So it's hyperechoic with a hypoechoic wall. Doppler will show tiny vessels can be seen in the wall. This large pleomatrixoma on the upper arm of a 12-year-old girl.
I think sometimes you see the ingrow hair.
Yes.
You see hair inside.
Yes, this is salivary gland. Enlargement of the salivary gland is either diffuse or focal. The diffuse mostly affect the parotid gland. It's bilateral in Sjogren disease or HIV, and if it was unilateral, this is indicate bacterial parotitis. So here we see enlargement of the parotid gland with some hypoechoic lesion inside. If it was unilateral, mostly bacterial. If it's bilateral, it occurs in Sjogren's disease or in infectious such as HIV. Teratoma, this is just for fun, rare in children, composed of all 3 germ cells. They often present at birth. On ultrasound, they are composed of solid and cystic parts and often contain calcification. they can have a close connection to the thyroid gland. Its extension is unclear. If its extension is unclear, MRI can be done. Here we see a midline tumor in the anterior neck, 3-day-old boy. Calcification we see cystic and solid component. So this is teratoma. It's not common. Last two subjects, neurofibroma and neuroblastoma. Neurofibroma, you will see it in a patient with neurofibromatosis. They will present in the subcutaneous tissue multiple. This is a 10-year-old boy with a known case of neurofibromatosis. He have multiple lesions in the subcutaneous tissue. On ultrasound, it appears like this. Last one is neuroblastoma. It's usually present as abdominal mass in young children. In the neck, it accounts for 1 to 5% of neuroblastomas. On ultrasound, it will be heterogeneously echogenic mass, often with some calcification. Thank you.
Well, thank you. It's any complete and thorough and detailed demonstration of the findings and